Good morning, folks. I think we are running slightly behind time. So what we'll do is we'll start off with a quick round of introductions around the table. And then we'll get into the specific discussion on what are some of the key endemic issues that are affecting the scalability and the viability of Indian healthcare. And what are some of the approaches that one should think of in terms of solving for some of those issues. So quick bit of introduction from my side for people who were not here yesterday. I'm Kaustav Ganguly. I'm a senior director with Alvarez & Marsal. I lead the healthcare consulting practice for Alvarez & Marsal in India and the Middle East. Alvarez & Marsal is a $1 billion global consulting firm, presence across more than 44 countries. India is clearly one of our key geographies. We are based out of Mumbai, more than 100 people working out of our Mumbai office. One of the key things that you would note about A&M is that almost a third of our global revenues actually comes from healthcare consulting. So healthcare really is our largest specialization area. And once again, one of the unique things that you would note about A&M's healthcare consulting practice is that most of my colleagues in the healthcare industry groups are former practitioners, former CEOs, COOs who were part of the healthcare industry, people who have been there, done that, run large healthcare organizations before coming into A&M. And these are the same people who now work in client situations working on performance improvement and turnaround management of healthcare facilities.
Hi, I'm Dhruv Simprakasam. So I'm the founder of a company called iClinic.com. It's ICLINIQ. Because people always think it's ICLINIC. So it's been 4 years since we started the platform. We are a global second opinion platform as well. So we have patients across 160 countries. We have been rated as 5th best telemedicine platform in the world by Healthline. We are the only company from Asia to be featured in the list.
Good morning, everyone. My name is Dr. Arjun Rao. My company, which I run, is called Sync Remedies, short form for Synchronized Remedies. We are into integrated medicine, where we integrate allopathic medicine with Ayurveda and homeopathy to provide effective treatment plans for patients for any ailment they have. We are into preventive care to wellness as well as therapeutic, and we are an online consultation service as well, like Dhruv's. But we also have a physical presence in Bangalore, and so that's short for what we do.
Hi, morning everyone. I'm Amit Gupta. I represent a venture capital fund called Jupiter Capital. Jupiter Capital is a fund based out of Bangalore. We manage a little under $1 billion assets under management. We are invested in industries like aviation, engineering services, real estate infrastructure, hospitality, media and entertainment. And we are actively looking at investments in the healthcare space, which is why we got interested in, we got associated with this event. Looking forward for a meaningful engagement.
Morning, friends. I'm Ratan Jalan. I'm essentially a student of healthcare. And I worked in the IT industry for 10 years, then advertising for another 10. I've been in healthcare for the last 20 years. I was with Apollo Hospitals, chief executive of one of their companies. I set up models like Apollo Clinic and the Cradle. For the last 6 years, I have a healthcare consulting firm, Medium Healthcare Consulting. We essentially do work in the area of new business model innovations, marketing, patient experience, some bit of market research.
Hi, good morning. I'm Mukesh. I'm representing Mentera. We are early stage social impact fund. We invest in healthcare, education, and agriculture with focus on impact on low income segments. We also have an incubator called Will Grow Innovations Foundation. We have been incubating early stage health startups, point of care diagnostic devices for the last 4 years. Thank you.
Thanks, everybody. So let me just take a couple of minutes to give you some context as to what we are really trying to discuss here today. So as we all know, I mean, there are some systemic endemic problems or issues which plague Indian healthcare. Now, our focus in this discussion would be to take at least 4 or 5 of those key issues and discuss some potential approaches or interventions which can solve those issues. So For example, I think one of the biggest issues that we are going to be talking about is the one related to access and delivery model viability. Very clearly, I mean, what we're really talking about is the skew in health infrastructure and resources across, tiers of towns and cities, and how does one solve for that? The second problem that we are going to be talking about is affordability. I mean, especially because you're talking about a very large proportion of the population coming from slightly underprivileged sections, not enough mature healthcare payment models or insurance models to kind of back them. So how does one solve for that? A good example here is if you take the example of any specialty, if you take the example of dialysis, for example, you're talking about 1.2 million people who are affected by end-stage renal disease conditions, and only a tenth of that population really having access to any kind of dialysis services. Now, a part of that problem is basically because of access, but the other part of the problem is also because there is very limited affordability. I mean, for continuous dialysis treatment around the year, you're talking about a total payout of around 3 to 4 lakhs, which is something that most families in India, or many families in India, don't manage to continue with. A third related factor is the fact that insurance penetration is still at a nascent level, nascent stage in India. Only a fourth of the population is really covered by any form of insurance, whether we are talking about government or private insurance. So once again, we'll have some discussion around, what are some of the key changes that are required for moving to a health economy with a far more mature insurance payment model. The fourth piece, I have obviously advised several health organizations over the years, and what I realize is that when I develop their strategic business plan, one of the key constraints always becomes the lack of availability of healthcare resources. And here we are talking about all kinds of healthcare resources: doctors, nurses, allied health professionals, as well as health talent. So we are going to be talking about that as well. And then the final couple of problem areas that we are going to be discussing, folks, is one related to the fact that data is still sitting in silos. We don't have quality data, and therefore we don't have quality analytics. Because we don't have quality analytics, we don't have the right kind of health decisions being taken. And also, because of the lack of data and lack of intent as well, there is very little focus on managing quality of health services, both measuring and managing quality and outcome of health services. So broadly, those are the 5-6 key issues that we thought we'd train our attention on in this panel discussion today. So to start with, I think what we'll do is, Ratan, I think I'll start with you. So we'll start with the issue of access, right? So, and as I was mentioning, I think on the one end of the spectrum, you're clearly seeing a good supply situation or an oversupply situation in terms of healthcare beds in some of the top tier urban clusters, with a complete proliferation of private healthcare models in the key metros and the top tier cities. On the other end of the spectrum, if you go beyond the top 50, 60 cities in India, you almost kind of fall off a cliff, right? I mean, in terms of non-availability of healthcare infrastructure as well as health resources. So one of the key things that I wanted to kind of get your perspective on is, how does one solve for this? I mean, when you're thinking of tertiary and secondary healthcare, how does one solve for this access problem, especially in the smaller cities and towns in India?
So I think let's first get the definition of tier 2, 3, 4 right. And I think anything other than Bombay, Bangalore, Hyderabad, Chennai, Delhi, Gurgaon, Calcutta, Ahmedabad, Pune and Cochin, 10 cities. Anything else is tier 2, 3, 4. Just to give you an example, if we think NABH is one proxy for quality healthcare, there are more NABH hospitals on Banjara Hills in Hyderabad than the whole of Bihar. So that's one ground reality. The second, I think somewhere we need to ask ourselves a very deep question. In healthcare, does distance matter? Is proximity a big deal? And it's so simple. If somebody has to travel from Guwahati to Chennai for a heart surgery, the person is less likely to travel alone. Somebody in the family is going to be with him. There is travel cost. There is the cost of stay. There is the livelihood. It disturbs business. It disturbs personal life. Equally importantly, there is this whole issue of post-operative care. The surgery is going to be there for 10 days. What happened thereafter? There is whole issue of follow-up care, etc., etc. So I think number one, travel for healthcare is a very unnatural thing. I think we need to realize that. And to that extent, it is going to come down, and it has to come down. Now, when people talk about that hospitals in small towns are not even viable, my take is that I do know that the prices in smaller towns are going to be on a somewhat lower side. Now, when you talk about the cost for that matter, the medical equipment is going to cost the same. The operation theater is going to cost the same. But the rentals are dramatically low. I remember when I used to have an Apollo clinic, in Dibrugarh we used to pay 8 rupee per square feet, and Bangalore was 150. Okay, the cost of doing the interiors is going to be less. Okay, the people cost is going to be less. The front office girl is going to cost less, technicians are going to cost a little less. And even when you talk about doctors, I mean, this country has 14,000 orthopedic surgeons. Out of 14,000, how many within courts are rock stars? So if you're going to open a hospital in Gorakhpur or Bareilly or some such place, can you have an orthopedic surgeon who is extremely competent, maybe about 8 or 10 years experience, can do an equally good job when it comes to simple knee replacement surgery as a big name surgeon, okay, and it's going to cost much less and it's going to be available. So I think the cost structure is certainly less, and to that extent it's going to be, personally I think it's going to be viable. But what we also need to look at is a slightly different point of view, which is what I call that if you're talking about a small town, look at the target price, that what is the kind of pricing which is going to work in this place, okay, subtract the margin which is acceptable to you and work on a target cost. The fact of the matter is, Indigo's punctuality track record has been better by and large than any other airline. And I remember when Indigo did the IPO, okay, they said that our selling price per average seat mile is the same as Jet Airways, our cost. So if Jet Airways cost structure is the same as Indigo's selling price, there is something which they've been able to crack pretty well. So I think you can't just take up a big hospital in a big city and put it in a small town and say it's going to work. It is not going to work. So I think it requires a very different mindset. Okay, can it work? I firmly believe it can work. And you do have examples which are pretty quality focused, good examples of healthcare in smaller cities. And they don't need to be 300 bed, we do everything kind of a thing. They don't need to be. I mean, you can very well be excellent secondary care. You don't need to do organ transplant and stuff of that kind. So I think it is very much viable. And personally at Medium, I think we have a very simple philosophy. If a place is a commercial airport, it probably has a medical college. If it has a McDonald's, if it has DPS, and if it has PVR, and if you are really fortunate, if it has a Tanishq store, it can very well have a good hospital.
Sure. Thanks, Ratan. I think it's interesting that you talked about the fact that force fitting is not really the right approach. I mean, you have to kind of, lay your cost threadbare, look at that particular catchment, look at that particular town tier, look at what pricing is going to work, and then work backwards. Now, moving over to you, Amit, I think, from an investor's perspective.
Sorry, I just have a point to add,
Sure.
in a dimension to the question you raised, as regards the deficit of beds and everything. And of course, we'll be guided by what Mr. Jalan says. I think in our country, one of the other parameters which is kind of fairly misconstrued is the average length of stay. Most of the cases, and in most of the hospitals which I have seen by myself experiencing a healthcare, the average length of stay in our country is elongated. And the primary reason for that is that most of the hospitals think that for them, occupancy is essential. Because most of the hospitals have either kind of landed up creating excess number of beds, or they have this in their minds that, beds is going to be perhaps giving them more top line. And the truth and the fact of the matter is that 60% of the revenue sits inside the procedure rooms or the operation theaters, and 60% of the cost sits outside the operation theaters and the procedure rooms. I have seen super successful hospitals in Surat, in Kanpur, who are 10,000 square feet, 6,000 square feet of procedure room and OTs. They've got 4 operation theaters, 2,000 square feet of recovery area, which is 16 beds, that's all, and 2,000 miscellaneous administration. So, specifically answering the question which Kaustav asked, One of the key changes which perhaps India is undergoing already and will have to undergo even more significantly is to have this barrier of average length of stay, which is an artificial barrier, crashed out. One of the compelling reasons for an average length of stay to be longer was also because insurance had mandated that you need an overnight stay. With the advent of ambulatory surgical care concept in India, and which was done very successfully by a company called Nova several years ago, and it continues to prevail in pockets in all corporate hospitals, insurance has blessed more than 700 type of procedures in which a discharge can happen in morning, evening. So the transition in healthcare from a test match to a T20 is absolutely imperative. And what that does is that significantly crashes the entire burden on the entire ecosystem of doctors, AHPs, practitioners, nurses, paraphernalia, number of beds, consequently better for the cost for the patient and better for the revenues for the provider. So that's one dimension to the deficit issue which has been spoken of.
Sure, I think that's very interesting. So essentially, if you take that kind of an approach, what it does to your overall cost structure on a per procedure or a per department or a specialty basis is that obviously it brings down your overhead costs, right, per procedure. Secondly, it makes your clinician and other support personnel costs also go down on a per procedure basis. So you're adjusting for the lower price by getting optimization or efficiency on both clinician resources as well as overheads.
Your gross margins tends to improve by almost about 700 bips. Sure. I mean, it's an actual maths.
Right. And I would imagine that as far as drugs and consumables and implants, DCI are concerned, that largely still remains the same, unless obviously you're going for generics or slightly less branded kind of stuff. But at least you can bring in efficiencies as far as your clinician costs are concerned and overhead costs are concerned. How about also thinking intelligently in terms of your CAPEX optimization for some of these smaller box sizes that you're talking about?
Yeah, so CAPEX kind of again varies quite significantly, again like the classification which Mr. Jalan quite rightly drew between tier 1 cities definition and 2, 3 and 4. So a very simple case in point is that you have to decide the kind of CAPEX you need for a Kanpur versus a Lucknow versus a Delhi. And I think that kind of significantly decides that what kind of ROI expectation you will have on your capital. That is point number one. Point number two is the breakup which I just now gave in my previous conversation, which is divvying up your infrastructure into lesser number of beds. The third aspect which Kaustav you raised, which is a connected point between your first question and your second question, which is the viability of some of these units in the tier 2, tier 3 cities, or in any city for that matter, is also that what is typically seen in tier 2 cities especially, and tier 3 cities also to a large extent, that every medical provider wants to be the whole 9 yards. They want to have a diagnostic, pharmacy, they want to have a lot of beds, they want to do medical management, they want to do CT scan, MRI, and they want to do the regular run-of-the-mill procedures also. Given a chance and a choice, they would also have a eye technician sitting there setting lenses in case they've got a good oculist and they've got a good eye specialist. I mean, that to my mind, I won't quote names, it's a completely flouted model. Whenever there is specialization, whenever there is focus, I have seen kind of centers making absolutely serious amount of money, not only at a gross margin level, but even at an EBIT level. I'm talking about earnings before interest and tax. And if hospital does not have a debt burden, they are always in the money. Some of the models which have been extremely successful in tier 2 and tier 3 cities is a model being taken by Cygnus Healthcare. They are kind of going and taking places on leases, which are completely underutilized facilities and infrastructure lying, which could be semi-government or autonomous or even government, and converting them into profitable units and working on a revenue share model of somewhere in the range of about 8 to 12%. So between a variety of choice of your model, crashing down on your length of stay, making a specialty focus, having a capex, you don't need to build a Leela of the same standard of Bangalore in a city where people will not have an appreciation for it. I mean, with no disrespect meant, the next $1 billion lies in the next 100 million people, right? I mean, everybody is kind of vying for a business model in those cities. So in all humility, I state that in those cities, the model has to be very smartly done. It's like the Taj Ginger model. So they build a ginger for a city which kind of will pay for that facility and for that infrastructure, if I may.
Sure. Thanks, Amit. So would you have some, perspectives on the viability of these models in lower tier towns?
I think we have the answer in the 4 A's. We need to get the availability first. If you have availability first, and then you get all other things, then comes accessibility, then comes affordability, right? The notion that healthcare is for affluent should go away, right? Because healthcare can actually be affordable for all. It's not for the wealthy alone. If you look at the models which have been successful in the rural areas, right? I'm going to quote the example from Tamil Nadu. Especially in rural areas in Western Tamil Nadu, you have family-run hospitals doing well. Right? Of course, right? You don't have the comfort in all other areas in India, but again, we can reinvent certain models which they are doing. Right? One is empowering the healthcare providers there. The second point is, I've seen various hospitals there having a low-cost approach. It can be actually professionalized with the approach they have. So I would say more of a heart-centric approach than a brain-centric approach is needed. Typically in these rural areas, like Ratan said, they're all rock stars, right? It's about identifying the rock stars and then grooming them. And one thing in the recent Clinical Establishment Act, what has been passed is you just need one clinical nurse, trained nurse for a better 15 hospitals, right? 15 better hospital. So the rest can be someone you can train. They could be a local person who actually knows to handle things. If you look at a hospital in the rural area, right, the best disinfectant is fresh air and sunlight. You don't need an AC there. So these are the models which we have to build. And if you notice, right, so in the rural areas, almost 50% of one's savings is spent on healthcare. 80% of India spends out of the pocket for the healthcare, because we had the earlier speaker talking about the insurance penetration. So we need to fix right, like I said, the first thing is the availability, then comes the accessibility, then comes affordability.
Sure, thanks, Dhruv. So essentially what we are talking about, folks, is knowing your customer first. I know it kind of sounds like a marketing jargon, but you need to know those particular catchments, those lower tier towns and their requirements better, and then choose what services you deliver and how you deliver them, with what resources and with what infrastructure. Essentially we are talking about that. Now, one of the things that obviously comes to my mind when you're looking at this whole disease burden is the role that preventive or primary care can play in terms of reducing hospitalizations and therefore also reducing the need for tertiary or secondary care health infrastructure. So Arjun, given your experience with respect to preventive and primary care, how do we make preventive and primary care viable and scalable models in India?
Right, so when you're looking at non-communicable diseases mainly, communicable diseases definitely you need to think about water, air and environment, and preventive care associated with all these things are extremely important. But the bigger challenge I think we also have is around non-communicable diseases, where we are looking at lifestyle disorders. All of us are living in a new environment right now and lots of things are changing. We work closely with IT companies and others where we have noticed that 25-year-olds are getting obese, having diabetes, having blood pressure, etc. So I think the first and foremost, the thing that we need to figure out and assess is how to increase awareness in the population around the need for preventive care. I think that's the crux of where we're going to get success, and what we have to do is work with government agencies as well as insurance companies and corporations to drive that home to every individual which is who are out there. We are working through Sync Remedies, we have done that as well. But I think the second thing is about early detection. There's been a lot of discussions about point of care testing as well, where we talk about early detection based on simple parameters that can be assessed to evaluate whether how prone the individual is for chronic diseases or lifestyle disorders. The other one is naturally next comes early intervention, where I feel that we lack in that effort. Because of the lack, complacency plays a big part from both the patient's perspective as well as the physician perspective, saying, "Chalo yaar, you're 25 years old, nothing will happen to you." When you know for a fact that both his parents are diabetics and have hypertension, and he's getting obese every year, we have to intervene. It is not being complacent about it doesn't really help. So I think all players play into this. And again, when I say interventions, I'm not talking about battery of tests as well as lots of medication that has to be the intervention. Intervention should be about simple things like diet and exercise, etc., which is something that can prevent a whole host of things that will actually happen to the individual going forward. It's nothing rocket science. I think all of us know about it, but I think we fall extremely short of doing any of these things from a preventive care standpoint.
Thanks, Arjun. I think you're basically emphasizing the need for early interventions, and early interventions would mean early consultations, preventive care models, and also, you know, point of care diagnostics as an affordable means of screening patients early on in their, you know, disease life cycle. But one thing that strikes me is that, you know, obviously this whole insurance system in India is currently typified by obviously poor penetration, but more importantly also very high, you know, payouts and very high claims ratios, principally related to hospitalizations. So once again, I think if one has to move towards better preventive care, I believe insurance systems have to work towards incentivizing primary care or preventive care. So Ratan, would you have some perspectives on, you know, how that shift needs to happen, and what really needs to change on the ground for insurance players to incentivize, you know, focus on OPD and preventive care?
See, the ground reality is that when you're talking about prevention, I mean, unfortunately, all good things in life are free. I mean, you drink a lot of water, there's no business model. You go for a walk, there is a business model around shoes, but nothing for walk. You know, sleep well and eat less. So eating less doesn't have business model, eating more has business model. So I think unless there is somebody who makes money out of keeping you healthy, unless the philosophy is that, I believe in olden days in China, a family physician used to get a fixed sum from a family. If anybody in the family falls sick, some money gets deducted. So the physician's role, actually if somebody fell sick, it reflected on how good a physician you are. So the only people who actually stand to gain by keeping you healthy are the insurance company. And that's a fact. And to that extent, whatever feeble attempt, if I may say, even globally, which have happened to keep people healthy, have been by insurance companies or their subsidiaries. You don't have anybody else for that matter. So I think unless you have a business model, which actually, like I said, and if you honestly ask me, if somebody came to Ratan Jalan and said, you know, they'll pay me $2,000 every month, I'll keep you healthy. And I say, and what are you going to make me do? Eat less and go for a walk? I said, GTH. So I think it is not as simple as that. It requires a very different mindset. And that probably is one of the reasons why it just hasn't worked even globally for that matter. I'm saying there have been, like you talk about things like, you know, I mean, tax on, you know, I'm saying beverages and stuff that kind. So I guess if you talk about governmental authorities, they do have the wherewithal or the statutory power, etc., to actually make the society behave in a particular way. So I think they can do a lot, but I think insurance companies or corporates for that matter, or in certain cases communities for that matter, can get pretty aggressive, and aggressive for the right reasons.
And what's preventing them from going down that route of incentivizing primary care, at least as far as India is concerned?
See, I think the problem with primary care in this country is, I mean, in the 2-day conference, you don't even find one person who's representing a clinic. Because in this country, healthcare is equals hospital. And even hospital, the large hospital, not even nursing home for that matter. We don't have a guy from nursing home here. Okay, so healthcare is large hospital. Now, the problem is, I remember when I did Apollo Clinic and Apollo Hospital, there were people who would negotiate with me and say, Ratan, your clinic doesn't have a bed? I said, no, it doesn't have bed. I said, not even one bed? I said, no, not even one bed. And the people would negotiate with me. Because like he said, the whole philosophy is occupancy. That if you don't have a bed, then what occupancy you're going to get? So I think the clinic or the primary care is a very different model. When a hospital does a clinic, it does it for conversion. So if you actually come to a clinic with chest pain, and if it's only a chest pain, somebody is going to feel disappointed. Because people monitor conversion rate. But if I have only a clinic, and that's my business model, and if actually it's a heart attack, I'm going to feel bad in a way because I have to send you somebody else, someplace else. So I think primary care, the clinic is a very retail kind of a philosophy. It's a very retail thing. 1,000 square feet, 1,000 across the country, is like Cafe Coffee Day. And very chiller item. And people who actually talk about 2 lakh of heart surgeries I mean, they're not going to get entertained by 80 rupees of ECG. It's a very different mindset. So I think, personally, I think, I don't expect actually large healthcare players to get excited about it. It has to be an outsider. So I believe, for example, HCL seems to be very interested in making a big inroad into primary care. Could they do that? They are a lot more likely to do it than a hospital player, because they would look at it in a very independent, mindset. They're not going to be excited about conversion, nothing of that kind.
Sure.
I want to add three simple points. The first is, right, incentives actually work. If you look at the ASHA workers, they are incentivized for bringing institutional deliveries and immunization. The second point is, there's a great opportunity for behavioral gamification companies. If one can influence behaviors, there's a great opportunity. Right? The third one is, right, so you have a couple of companies already getting into this space, which have got a fair amount of success. Like Goki is one example, and it's like a crowdsourcing kind of thing.
Sure.
Just a couple of-
Arjun, I think you also wanted to make a point.
Quick point. With respect to insurance companies, which we were asking earlier, what we have noticed is that the insurance companies, there is a TPA and then there's a corporate or a retail individual. And what we have noticed in this value chain is that the incentives are not really well aligned, right? So somebody pays a premium, the person who's trying to pay a premium is trying to figure out how to reduce the premium in the coming year. The second one is the TPA, whose incentives is actually aligned with the premium. So he's actually incentivized to get higher premium. So naturally, wellness and preventive care is not really well aligned. Next is the insurance guys, who are actually ones who are paying the money but have the least influence, because they are not having the influence because of the TPA in the middle. So they are once removed from the actual corporate or the individual. So there is this disincentivization process or a misalignment of incentives between all the three parties. So when we were talking to the insurance companies, what we have noticed is a few of them have now, and the second thing, before I jump into that, the second thing is, right now the insurance is only for inpatients, admissions, not for outpatient, right? So majority of the insurance guys don't cover it. So naturally now the incentives are aligned to actually admitting a patient for treatment so that they can get the money, because otherwise treating them in a clinic doesn't yield them much, because you get the 200 rupees from the individual for out-of-pocket expense, and that's pretty much it. So the incentives are right now misaligned again, between the insurance as well as the provider itself. So when we're talking to the insurance folks, what we have realized is a few of them, like Bajaj and HDFC Ergo and others, are going down an OPD route, where they want to provide an OPD policy for individuals to take on or for corporates. And that's when actually where we were going to see wellness and preventive care really playing out, because that's when we will get actually paid for doing preventive care as well as wellness as well from an outpatient perspective. Until then, the incentives are completely not at all aligned. And even individuals are not motivated, because if the corporate doesn't cover it, I won't do it type of an attitude.
No, I just wanted to add a couple of points here. I mean, there's a lot of, with no disrespect meant for any representatives here. So there are only about 27 TPAs we have in the country. The whole process of settlement of claims from hospitals and from patients is extremely kind of archaic. There is a one-size-fits-all approach which has been kept by the TPAs and the insurance companies. So they have not even factored into account that, how much a lab chole should be costing between different type of cities, between different type of facilities. So they say that, okay, this is our lab chole rate and that's it. What it does correspondingly is that for the healthcare provider, there is this constant urge of making the claim to be higher, because there is this embedded notion that when we will be sending our claim, there will be a 30% deduction or a 20% deduction. As a consequence, there is neither the payer nor the payee nor the TPA, there is no trust between any of the parties. So like Arjun very rightly said, there is a complete misalignment. What it leads into is that they tend to make the patient stay longer. It goes back to the original point which I made on length of stay. They make the patient go through a battery of tests, because those are the areas where they tend to have a much higher margin. Then they send a higher claim to TPA. TPA will cut it by 30-40%, and the patient at the end will always be at the receiving end. So, I mean, the whole chain, according to me, is so kind of imbalanced, and the kind of interests are so misaligned that it will take a significant amount of effort from the GIPSA levels, from the insurance company levels, to kind of make this fall in line. Another big dichotomy is when you go to insurance companies and compare the rates which they have approved, they are abnormally different with what the rates are with the central government, the CGHS and the ECHS. So, I mean, a lab coli is a lab coli is a lab coli. It cannot cost 20,000 bucks with a CGHS, and it cannot be 40,000 with a TPA and with a regular insurance company. So, all of this kind of leads further to the chaos. And as a consequence, the premium to settlement ratio, there is this, like I think in the earliest discussion Manish rightly mentioned, that this belief that, you know, if we will pay this premium and the benefit which we will get, also seems to the people who have to take insurance that it's never going to kind of, you know, balance out.
Sure. So it's almost like a vicious cycle right now, and with different stakeholders in the ecosystem working towards different objectives because their incentives are all misaligned. And that's something that we need to solve for. Just changing track a little bit, but you know, Mukesh, I know that your company has you know, a point of care diagnostics company as part of its portfolio, right? Now I'm pretty excited about that space because, you know, I've been fortunate enough to work with somebody who had built a point of care diagnostic solution and had taken to you know, Jammu and Kashmir, working with the state government. But what I noted there is that it's not really about just, you know, developing a low cost and therefore accessible solution and just, you know, putting it out there. It's not about selling boxes. And for usage to really pick up, there has to be a very, very clear focus on service management. So just wanted your perspectives on, you know, what are some of the key levers that can make point of care diagnostics a real disruptor and democratize, you know, health access in the smaller towns and cities? And what are some of the watch outs from your perspective, once again?
Yeah, so I think point of care diagnostics is very exciting space. With the increasing disease burden in far-flung areas, you talked about Jammu and Kashmir, our entrepreneurs are working in rural areas in Rajasthan and Ladakh. There is no way you are going to be sending, you know, physicians, you know, health workers from here to those places. Communicable disease burden, infectious disease burden is increasing. So point of care diagnostic is really needed. But a lot of entrepreneurs have taken a very short-term approach of just selling a product. Even if government buys the first installment of the products, first installment is released, small pilot is done, the usage is not there, it's not going to increase. So it is very important to look at the whole cycle, incentivize everyone in the chain. Just convincing the bureaucrat or the minister is not enough. The ASHA worker has to be incentivized. It needs to fit into their routine. It needs to fit into their skill levels. What you've also seen is when you make these point of care devices, connected devices, when there's geotagging involved there, when there is a health data that is coming out, and you know that the disease burden is increasing in certain districts, and then there is a targeted spending happening from the government, focusing on those increasing burden, that is where we see everyone focusing on the right areas. So then the usage is increasing, the entrepreneur knows, the government knows, the people in the system know that the usage is not happening and what are the reasons for that. So connectivity is important, looking at the data is important. The biggest gap is also training. When you go into rural areas, if a small group of health workers is trained, they're not necessarily going to be around for the whole year. If the person changes, then there is mental block, training is not given to the new person, so then the usage again dips. So this constant focus on training, there has to be one person within that district who's a master trainer. You can't all the time send the entrepreneur or someone from Mumbai, someone from Bangalore to constantly keep training people. So focus on training, focus on connectivity and data are three important elements that have to be looked at.
Sure. So the outlook really therefore needs to change to service management and training and hand-holding aspects, looking beyond the box that you're developing. And that change in outlook needs to happen both on the seller side as well as on the buyer side.
I also think that in addition to that, government has come up with some very, very good programs. So PPP is picking up, National Health Mission has recently released free diagnostic services guidance. So enabling mechanism has been put in place by the government, but there's a lot of pushback from the private segment which is not comfortable with private, this point of care diagnostics. So if someone sitting in Mumbai is not going to go into smaller cities and villages and deliver, then they might as well constructively contribute towards creating protocols rather than continuously objecting. right? The healthcare is not reaching there. So you need clear regulatory protocol, government is creating enabling mechanism, everybody has to work towards it rather than keeping on, picking up gaps there and saying this will not work.
Understand. Just changing track a little bit, I think one of the things that I talked about earlier in the discussion is this whole paucity of healthcare talent, not only doctors and nurses and allied health professionals, but there is a complete dearth of professional healthcare management talent and leadership as well. So Ratan, going by your experience, and you've kind of run fairly large enterprises in the healthcare space. So how does one keep solving for this continuous issue of lack of healthcare talent and current engines for producing such talent being completely non-existent or broken?
So I think if you're talking about the clinical talent, like I mentioned, there is this, like I said, that if there are 14,000 orthopedic surgeons, 15, 20,000 intervention cardiologists, you do have a whole lot of clinical talent around us. You do have. I think that the constraint has been this whole belief that it's the doctor who gets the patient. And to that extent, there's hunger for getting the most famous doctor in town. And in the process, everybody else gets reduced to a supporting cast for that matter. So I think, for institutions to believe that we can create a brand, we can create an organization which stands for good quality, and then we can have people who are competent, who need not necessarily be famous, and who can deliver clinical outcome which is as good as somebody else. So I think that's a shift which is very badly required in healthcare, honestly. That's one. Two is, when you talk about you don't have enough managerial talent, I think healthcare has to start getting more and more appealing to young people. And I remember my early days when I used to go to IMs and ISBs of the world. When I was in Apollo Hospital, I think there were serious mindset issues, I remember the first poster I had in ISB when I went for a career opportunity talk, it actually said doctors also allowed. Okay. Because, you have young people, very bright people, and the first question they ask you, but I'm not a doctor, what am I going to do? So I think things are changing, they need to change a lot more. But more importantly, people actually have to be allowed to play a much larger role. Today we are talking about a large hospital chain in Hyderabad, and you won't believe it. You realize that the physician community within the hospital is the untouchables. You can't do anything about it. And somewhere, as a matter of strategy, the entire administrative pool are the people who are very average. And it seems to be a very deliberate strategy. Because tomorrow, if you get a talented guy for marketing or finance or HR, okay, he's going to stand for himself. So I think there has to be a certain environment which has to be a lot more supportive to talent. It has to get a lot more appealing as an industry, which I think is changing. And the third thing which I said is that people somewhere have to, get less enamored with this whole celebrity physician piece.
Sure. I think you're basically talking about a mindset change. And so talent does not mean only physicians. Look beyond physicians. Everybody else who is involved in conceptualizing, planning for delivery, and actually involved in delivery also qualify to be called talent.
See, people tell me that why will a neurosurgeon go to Moradabad for that matter? And I say, why does a IM MBA go to ITC Saharanpur? Or go to Lever's Bareilly depot? He does. Because you promise him a future. So do you have hospitals in this country which actually have a HR philosophy? So, we can keep on talking about talent shortage, and we can keep on living with self-fulfilling prophecies, but I think the truth is not exactly what it is being portrayed.
There's a lot of merit in what Mr. Jalan says. We've spoken of kind of medical talent deficit ad nauseum. I've got just two dimensions to add to it. One, on the supply side, although I do believe strongly, like an IIHMR we do not have many more institutes who are kind of churning out, administrative professionals. The second thing which I believe very strongly, and I've seen with close quarters, is that both the paramedics, the administrative staff in healthcare in India is not paid commensurately. And that's why we see a significant flight of talent, not only at the doctors' levels, but at the nurses' levels and at the paramedics' level. I mean, we are speaking of purchasing power parity with majority of the nations. The nursing staff in our country gets far lowerly paid than in Sri Lanka. So, I mean, I just don't understand. And the reason for that, somewhere, without kind of taking any offense on the clinician community and the doctors who run these institutions, is that they do tend to come with the philosophy or with the mindset that, we can still get away with all of this. Since we are there, we are going to still anchor this place, and it's going to do well and it's going to run well. Not a single hospital which I know of in my knowledge, and I'm sure they may be existing, have an ESOP scheme for employees. So if you have to talk of people being engaged with you and having a commonality of your purpose and vision, then you have to make them partners. So they are not stakeholders at all. They are indeed, in some cases, second or third grade workers, in the institutions.
There's also a need for investing significantly in training healthcare professionals in smaller cities. There's need for 6-month courses, because today diagnostic test cannot be given without a signature of a pathologist. How do you do remote diagnostics? So there has to be enabling mechanism, and there has to be supportive protocols and standard operating procedures for that.
There are enough labs which stock pre-signed diagnostic reports by the pathologist. Enough. But nobody will talk about that.
Right.
Because somewhere it boils down to losing territorial rights. That if I'm a pathologist, I'm entitled to a certain sum of money. Anything which actually impacts that scope is not a welcome thing.
That is acceptable, but remote supervision is not acceptable.
So a set of people are missed actually, Ayush, right? We can involve them in the whole healthcare ecosystem. We have almost 32,000 Ayush people, right? Give them 6 months of training, like Mukesh said. They can be brought into the primary care system because they study the same anatomy, right?
I think we are running short on time. So just, a couple of final points that I wanted you, Dhruv, to comment on, and you, Arjun, as well, are related to the fact that first, data is basically sitting in silos. So, and it's not quality data, both on the private as well as the public healthcare side. So what are those, 2-3 magic bullets, if there are any, with respect to, having integrated electronic health records, which you can then do analytics on? And Arjun, one final bit from your side on quality management and clinical outcomes, because while we keep talking about access, affordability, and a whole line of other A's, we don't talk about quality management and clinical outcomes. So what needs to change on the ground for that focus to come in? Dhruv, you first.
So we have Eastern problems and we have a Western approach with people who study in the West, right? So we need to look East. China has solved this problem in a brilliant way. So they have their national identification number, and the health records are interoperable. US is just getting into interoperability with the meaningful use. So when we link Aadhaar with the health records, we're going to solve a major problem. You'll be able to solve the non-communicable diseases problem, and the epidemics can be solved easily. All those things are, for instance, say in a normal government hospital, you go at 7 a.m. in the morning, right? A person comes and registers, he gets an OP number. The next time he registers, he gets a different OP number. So at least 15 minutes are wasted there. Imagine it as a single number to track that. So it's actually a data inclusion and much more. And second point is, right, so we'll be able to solve brilliant things with big data. For instance, China solves, we have less than 30,000 gynecologists in India. China also has the same problem, right? So they have of course, it'll be kind of scandalous to tell that, but they have a different way to solve it. When one gets mad in China, the next question they ask is, when are you going to planning your baby? Right? That's a tricky question, right? So there's actually a huge data analytics team and science behind it. So what happens is, right, so they pool gynecologists to one particular area in a province, and then, the whole ecosystem happens, right? So the first trimester, second trimester, all the vitamins and, whatever stuff are bought. And in the 10th month, you have all the gynecologists pool there, and all the, convention centers, schools, they're all changed into maternity wards, and you have the, the deliveries happening. So MMR is really low in China. There's one point which we can try to bring here, right? So the integration of Aadhaar with health records, that's going to solve a whole gamut of problems.
At least the basic bedrock is already there. You need to build on that.
Exactly, right? So a lot of startups can build on it.
Fair enough. Arjun, one final minute from you.
Sure. So clinical outcomes is a critical component to a good, efficient, and effective healthcare delivery. I'm sure everybody will agree to that. The problem is, how do you define good quality outcomes, right? And how do you define clinical effectiveness in any delivery model for that matter? And I think it is about merging clinical performance along with operational efficiency to decrease cost overall to the system and the burden itself, economic burden it has on healthcare. I think the way it has to be done is through a few things. First is naturally regulations that has to put in place. NABH is a good example where they're trying to standardize quality of care and quality assurance, so to say. But in addition to that, I think clinical competency from all healthcare delivery aspects is important. How do you actually deliver good quality care? And so physician assessments as well as nursing assessment, et cetera, has to be done. And thirdly, how do we evaluate what is operational efficiency while driving good clinical outcome? And I think data analytics is a very critical component to that. EMRs are coming around to help in that process as well, where one, you build in clinical decision support into the EMR so that you build in good clinical outcomes based on evidence-based practice. And secondly, the EMRs also is a data repository, which in turn can be mined to evaluate where the outcomes are, what the outcomes are, and where the outliers lie. And I think that is a critical component of evaluating how well any system is actually performing from a clinical quality perspective.
And thanks for your perspective.